Welcome to the STEM Pathways podcast, where we delve into the fascinating world of science, technology, engineering, and math. I'm your host, Rohan Sharma, a passionate explorer of all things STEM. Each episode, we bring you captivating stories, cutting edge research, and inspiring interviews with experts and enthusiasts who are pushing the boundaries of innovation. Whether you're a student, a professional, or just curious about how the world works, join us as we unlock the mysteries of the universe and explore the endless possibilities of STEM. Let's get started. Today, I'll be interviewing Dr. Matthew Cooper, who has an MD at New York University. How are you doing?
Good. My pleasure to join you today, Ron.
Yeah, thank you. So to get started, I wanted to ask you what made you choose your major when you were going to do your undergrad?
So, for my major, before I started college, I was actually thinking about music or medicine. And I thought that music might not be intellectually challenging enough.
What
Not
instrument do
sure I
you
was
play?
right. Clarinet and sax.
Oh,
And
me
so I
too.
thought that if I chose medicine, I could still play music, which I have. So that I knew that I wanted to be pre-med. I had AP credit for calculus. I wasn't planning to be a math major, but I took second semester calculus, loved the professor. So I took the next course he was teaching, which was differential equations. Um, Took the next course, which was linear algebra, and took the next course, Fourier series. So at that point, I was halfway through a math major, but I was also a biology major as part of what was a pre-healing arts program at F&M.
And what was your experience like while doing the biology part of your major?
Well, it was good preparation for medical school in the sense that a lot of it was read, memorize, and regurgitate. So not a whole lot of thinking, at least in the first couple of years of biology or medical school for that matter. Certainly as you get to higher levels in most things like medicine, like engineering, you get to apply what you've learned. And that's where you really develop your own skills, you develop the confidence, to develop the applications.
Yeah. What made you decide you wanted to do an MD?
Well, again, by the time I had started college, I had decided on medicine. I was influenced by loss of a brother when I was 8, he was 6, and that was really a driving force to try to change outcomes for future patients.
So you went to NYU for your MD. What was your experience like there?
Well, it was overall great. The first couple of years of medical school or book learning, whether it's biochem or anatomy or some of the other things. But once I finally got to patients in the third year, it was great. It was everything I had hoped it would be in terms of patient evaluations, patient interactions, and starting to learn the art of medicine.
Yeah. And then how many years was your med school?
Med school is usually 4 years, which is what mine was.
Oh. And then I'm assuming you did a residency after that.
So I did several. So I did a
Yeah.
couple of years of general surgery. And since I was on an academic track, I went off to the National Institutes of Health, did immunology and transplant research for 2 years, then finished my general surgery, including chief resident general surgery. And those 2 years were remarkable for a lot of kidney and pancreas transplants. My research had been on primate xenograft transplantation across species. And so I had the transplant bug. Then after finishing general surgery, I did cardiac surgery at Columbia University, where we did a lot of heart and heart-lung transplants, which was just terrific. And then off to London for the Hospital of Sick Children, Greater Ormond Street, where I did pediatric hearts and pediatric heart transplantation.
And do you still do heart transplants and lung transplants?
So I did that up until the time I left practice. I left practice about 10 years ago. And I had already gotten my MBA in design, and was looking to have a broader impact than 1v1. When a doctor treats a patient, whether it's an internist or a surgeon, it's one at a time. And I wanted to have a broader swath and a broader impact. So I joined 3M Healthcare, and I was there for about 10 years. and most recently as Vice President, Medical Affairs, Corporate Health and Safety.
Can you talk a little bit about the preparation that goes into doing a major surgery such as a heart transplant?
Sure. So you have to do the book learning. You have to understand the procedure. You have to understand the steps. And I think one of the things that was effective learning for me in surgery, and I think it probably is in other disciplines as well, is that as you read and maybe have an incomplete understanding, and then you experience something clinically. And then when you go back and read it again, it really locks in. You have that clinical exposure to really give you the reality, give you the precision of what needs to be done. And so you need to learn the steps of the procedure. By the time you get to do a heart transplant, you've been through general surgery already. You've been through the preparations of understanding the physiology of stopping the heart, maintaining the circulation. So when we do cardiac surgery, not transplantation, very often we put the patient on the heart-lung machine, which maintains circulation, blood pressure, oxygenation. So the heart transplant's a little further than that. We put the patient on the heart-lung machine that maintains the patient, maintains blood flow to the brain and various organs, and then we take out the heart. And then it takes about 35 minutes to sew in a new heart. But very often, such patients have had previous operations, so there's a lot of dissection because of all the previous adhesions, the scarring from the previous operations.
When you have to put a new heart back in, how many different points do you have to connect the heart to?
Yeah, so there are a couple of different ways of doing it. You can either connect it on the right side of the heart by the superior vena cava, the inferior vena cava. One of the more modern advances is just to connect the right atrial cuff. You need to connect the left atrial cuff as well, and then the aorta and the pulmonary artery.
And how are
So
these
you
connected?
yeah, yeah, it's connected old-fashioned sewing. That is polypropylene suture, which is a lot in consistency like fishing line. And it's actually swatched onto a curved needle, and it's an overhand technique. And so most surgeons are pretty good at sewing in the OR, but they don't necessarily darn socks at home.
And then when you're making this seal with the sewing,
Yeah.
that has to be like a tight seal that no blood could exit out of, right?
Has to be watertight. So can't make it too tight because otherwise you'll either tear the tissue or deprive the blood supply to the tissue, making it ischemic. So you make it just right, and then when you remember that the heart is empty when you're sewing it, and then when it fills up, it actually brings the appropriate tension to the sutures to maintain it as watertight. And then of course you have the clotting mechanism as well, which ultimately is the final seal.
Mhm. Um, how much practice do you put in learning how to stitch these together alone?
Well, when I was a junior resident, they talked about taking a raw chicken, tearing it apart, and sewing it back together underwater. Not sure I ever did that, but the reality is, when I learned, and I think it's still true, you learn by doing. You learn first by sewing skin, and then you start doing more basic operations, and then it proceeds. More and more, there's interest in the development of high fidelity simulation. And while it's not quite the same consistency of tissue, it does help.
Yeah. Um, I've just heard of this online and stuff, but I heard that modern surgery they'll do it with a robot, and then the surgeon will be sitting in some sort of contraption, so they make really precise movements with this.
Yeah.
Uh,
So the robot is adjunctive, right? So there's always a decision whether the robot will add anything. And so the first question is, the robot is usually minimally invasive. So the first question is, do you need it for the heart through a big incision? Can you do it through a smaller incision, so-called minimally invasive? And do you want to do it by thoracoscopy or laparoscopy, that is a lighted scope, or do you want to use a robot? For years, we were doing surgery with a scope, and the robot is really the enhancement of that because you're still working through a small exposure, small incision. The visualization with the robot is much better, however, as it's a depth of field. and then you're using obviously um, robotic arms to do the procedure. But I think the important aspect is the robot has to improve outcomes. And if it doesn't improve outcomes, it doesn't add anything because there is an incremental cost. But if it either increases the outcome of the patient, reduces the risk, reduces the morbidity, reduces mortality, decreases the time to the operation, then it's doable.
Have you ever worked with these?
I have, I have.
And
And
then,
the console that the surgeon works from is just that. And you can practice, for example, by peeling a banana with the robot and sewing it back together, or peeling finer things and sewing them back together. So there is a lot of practice to be done. You know, surgeons who grew up doing video games with that sort of hand-eye coordination, I think are at an advantage as well.
yeah. And what are you controlling when you're doing this?
Well, so once you make so usually you have two surgeons. One is at the console. The other one is at the bedside. And so you actually put in the camera through one port. You put in a retracting arm that is to hold the position of tissue. And then there may be one or more instruments that are actually the extension of the surgeon's arms or hands. And so what the surgeon's doing is controlling those instruments to either dissect, to cut, to sew.
And then they keep swapping out these instruments for whatever job
Right.
they need.
Right, exactly.
Mhm. And then when they're using these instruments, like for example, for a heart surgery, would they do like the starting part of the surgery, like opening the person up and everything by hand usually, and then use the robot for the
Yeah.
most precise stuff
Yeah,
inside?
and again, the robot is usually used for minimally invasive. So there are relatively small incisions, or as we would refer to them as port sites for the operating ports, which are relatively small, and that's done by hand.
Mhm. And when you're doing this, where's the camera?
So when you make the initial incision, the camera may be in the room itself and it may be in the overhead light. Once you start the internal part of the procedure, the camera is part of the fiber optic, if you will. And that is there may be a fiber optic light or other sort of light in the operating field, and then the camera goes into to a port of its own.
Um, what's your favorite aspect of doing a surgery?
Well, I think it always has to be directed at the potential to improve the patients. And I think, the most fun thing about a heart transplant is at one point you're looking down in the chest and there's nothing there. And then you sew in the new heart, and usually they start up on their own. And then you've given a new life to somebody. So it's a pretty amazing ability and opportunity to participate.
Yeah. And what kind of cases do people usually require a transplant for?
Sure. So they may have, it's usually what we call end stage, and that is that medications can't help them. Angioplasty, stenting of coronary arteries, restoring blood supply can't improve them. So the hearts tend to no longer pump well enough. Both the right heart and the left heart in particular don't pump well enough for circulation. Patients have heart failure. They're functionally impaired. So those are the patients. And the reasons that that might occur are from a chronic insufficiency of adequate blood supply and oxygen carriage to the heart. It may be sometimes idiopathic, that is, sometimes hearts dilate, enlarge, and stop working, and we don't know the reason. That's idiopathic. It can occur as an end result of congenital heart disease. Usually, we try to palliate congenital heart disease with more conventional operations, but sometimes we can't make that as good as we want for as long as we want. Some of those patients come to surgery and ultimately transplantation. And then there are some infectious diseases, either viral or other, that can cause sufficient heart failure that leads to a heart transplant.
Oh, what are the after effects of having a heart transplant on someone?
Yeah, most patients feel great. From the standpoint of new circulation, new pump, they're getting more blood flow to the brain than they got before. They feel good. However, there is another side to the transplant, and that is there are a lot of drugs and medications that patients require. First, to prevent the rejection of the foreign tissue, the foreign heart. Um, and so it is trading in some respects one medical problem for another. However, we're getting better and better. It's not perfect yet, and patients have great longevity. The long-term risks of heart transplant are also the fact that we have to knock down the immune system to tolerate the donated and the transplanted heart. And so sometimes that makes patients susceptible to certain cancers like lymphoma and also to certain opportunistic infections. So it is a balance, but by and large, it's a new lease on life.
Yeah. Uh, I'm guessing it's complicated for a lot of people to understand, but can you explain the mechanism that makes a body reject a foreign organ?
Sure. So it's a little bit like a very old movie that I recommend most people see, which is called Fantastic Voyage, many years ago. But the idea is that part of the body's system of maintenance is to recognize anything foreign. So that helps us deal with sorting out infections. It helps us sorting out possible things that lead to cancer to a certain level. And so in that body system, there are several types of white blood cells. There are also killing functions of other aspects of the body that allow it to target foreign material. So when you put um, foreign tissue in, or you put a heart in from a donor, the body recognizes the different proteins, the different antigens, the different what are called histocompatibility factors as being foreign, and thereby both antibodies from B cells and also the T cells attack those tissues. And so we need to treat the recipient of transplants with medications to suppress that reaction.
Yeah. Uh, Going back to your journey to actually becoming a surgeon. So obviously you do your undergrad, then you spent 4 years in med school. So do you spend the first two just doing studying, reading books and learning, and then the last two, I'm guessing you still have classes, but then you're also doing hands-on work?
Yeah, and again, med schools, some of them do it differently, and sometimes they integrate a little bit more clinically early on. And we had some clinical in the first couple of years, clinical meaning actually dealing with patients, but by and large, the first 2 years of the books and labs, and the last 2 years are the clinical.
And then is medical school different depending on what you're trying to go into?
Yes and no. The foundational stuff is the same. Usually by the time you get to fourth year, you're able to take some electives. So you can start to either experience or sample things that you might be interested in, or you can start to focus. Uh, so, for example, if you're going into surgery, you might start taking surgical rotations as a medical student. I actually found that some of the best rotations I had as a fourth year student were not surgical. They were actually medical in an intensive care unit and an anesthesia. So I learned ancillary skills or ancillary approaches that were valuable to me later on as a surgeon.
And what's ancillary mean?
Um, Part of the team, basically. That
Oh,
is, that is, much of what we do is a team sport. And so if it's not the surgery, it may be the critical care, how the people take care of the patients, the lung doctors, the infectious disease doctors, all that. So it's the other parts, the assisting parts.
yeah. And then after medical school, how long was your residency?
Mine was about 9 years.
Yeah.
So
I'm guessing because it's surgery, it's much longer.
yeah, it's usually 5 years for general surgery. I also spent 2 years in research, and I got 1 year of clinical credit for those 2 years of research at the NIH, and then 2 years cardiac, and then a third year of cardiac doing pediatric hearts. So
And
cardiac
then,
surgery tends to be among the longest, as is neurosurgery as well.
And then, as I've heard things about being in residency, is it true that you're working like 80-hour weeks?
Oh, we'd be lucky if we were only working 80-hour weeks. So during the latter part of my training, when I was already a fellow, there was something called the Bell Commission in New York that resulted from the unfortunate death of a young woman who happened to be the daughter of a New York Times reporter. And it prompted this commission, which looked at fatigue among residents, and they started to limit the hours. Um, and that's where the 80 hours came from. And it's interesting that in some specialties that applies for junior residents. It doesn't usually apply for the senior residents and fellows. And it's a mixed blessing. Even though you have fewer hours worked, um, patients get many handoffs, and so consistency of care is challenging under those circumstances. You know, the thing that surgeons always said is if you're on call every other night, meaning you're off 50% of the time, you're missing 50% of the action. And I think it is true to some degree that you're there as a resident physician to maximize your experience. And I think one of the things that you do learn is how to function with chronic fatigue and to make effective decisions under chronic fatigue. Not that you're always optimal, but that's the reality of what practice will be like later on.
And then, wait, so do you spend most of this time being on call every other day?
So most of my residency, particularly in the senior years, was every other night. When I was a chief resident in cardiac surgery at Columbia University, I was on every night. And we were doing transplants almost every night.
Really?
Yeah, it was exciting, like all the storybooks. It was exciting and dynamic and just terrific.
And then, was there, I guess, a surgeon above you, like the chief surgeon or something?
Yeah, so
Because
even as a chief resident, there are so-called attending physicians or professors, particularly in an academic center, who are above, who have ultimate decision. But part of the training process, particularly with surgeons, and it's true of other physicians, is to have more and more independence. And for surgeons, more and more independent operating privileges. So when I was a chief resident at Columbia in cardiac, a heart transplant was a resident case without an attending in the room. So that's the evolution, if you will.
yeah. Um, can you talk about when you're in the room doing a heart surgery, and then I guess even for the prep, like right before it, how many people are involved, whether they're nurses, doctors, or
Sure. So usually there's one surgeon, there may be a second surgeon assisting, there may be a resident, there may be a physician assistant assisting. There's usually either a scrub technician or a scrub nurse, also scrubbed. There's an anesthesiologist, and they may have an assistant as well. Sometimes what's called a CRNA, which is or a nurse anesthetist assisting the anesthesiologist. There's usually one person running the heart-lung machine, that's called a perfusionist, and then one or two nurses, circulating nurses in the room who are not sterile, who can fetch things as needed or open things as needed. So it's a pretty big team, if you will.
yeah. And then is there someone coordinating all of this?
Well, the surgeon's the coordinator. You know, it's not necessarily true that they're the captain of the ship, as may have been once perceived, but it's definitely a team sport, and there has to be one person where the buck stops, and that's the surgeon. But again, it's a team sport in the sense that very much what the surgeon does is enabled by the anesthesiologist. Very much the successful outcome of the operation is a result of communication among the team.
Uh, I was wondering how much specific preparation is there patient to patient?
Yeah, so in general, a patient coming to say to see a heart surgeon will have had a bunch of diagnostic studies. And so when the patient comes in to see the surgeon for evaluation for an operation, at that point, the surgeon would review all the previous clinical evaluations, all the previous diagnostic studies, make a determination in their own mind what the appropriate care is, and then meet with, talk with, examine the patient, and then discuss the therapeutic options, and then decide on a plan. And then there may be specific things that need to be prepared in terms of available equipment or other things for the operation. Usually, we review the morning of, say, if I have a specific patient, I would review pertinent films like angiograms, films where we actually inject dye into arteries, things like that, to get a roadmap of what we're doing the morning of. And you develop a almost eidetic memory of patient specificity. And with that final review, when you walk into the OR, when you look at the patient, all that is a resource you can tap on. One of the things we do, however, in the operating room before we start with the whole team is to make sure we're all on the same page in terms of whether it's the right patient, the right procedure, the right side, all of those things.
Yeah. Um, so what was I about to say? Uh, wait, so when you're doing these surgeries, um, from when the patient goes under, how many hours does it take?
So for example, for an average coronary bypass surgery or a valve operation, operating time is about 2.5 to 3 hours, but there's usually at least an hour of preparation time, getting the patient ready with anesthesia, putting intravenous and arterial lines in place, things like that. And then another hour on the other side, uh, closing up, drying up, making sure that they're not bleeding anymore before they get to the recovery room or to the intensive care unit.
Yeah. So when you did heart surgery, was it only transplants or do you do other?
Nope. No, I did coronary bypasses. I did all sorts of valve replacements, repairs, replacing the aorta, aortic aneurysms. I did thoracic and vascular surgery as well. So a lot of lung surgery for cancer or other things, and a lot of vascular surgery, whether aneurysms or bypasses and such.
And were these ever emergency surgeries
Sure.
or
Percentage of them were.
Mhm. I'm guessing those were like heart attacks and strokes and stuff like that.
Well, for a cardiac surgeon, we don't necessarily operate on an emergent stroke or emergent heart attack unless there are complications. So, for example, somebody has an acute heart attack, they might not need an operation unless that heart attack is sufficiently severe that they've ruptured one of their valves and they go into florid heart failure and can't maintain a blood pressure. Or sometimes they get what is called an ischemic ventricular septal defect. So when you have a heart attack, heart muscle dies. And so if you have sufficient death of heart muscle in an area in the septum, the wall between the main pumping chambers of the heart, that can create what's called a ventricular septal defect. And that becomes a true surgical emergency. And but obviously there can be ruptured various parts of the heart can rupture. There can be trauma, whether blunt or penetrating trauma that can require emergent operations as well.
Uh, I was wondering, so a minor heart attack, what's the usual treatment for that? Is it just putting in a stent or
Well, so it depends. Um, Sometimes it's a medical treatment. Sometimes it may require an angioplasty or a stent or something like that. If there are multiple vessels involved, it may require a coronary bypass. It really depends on which arteries are involved, the severity of the heart attack, that is how much muscle is initially lost. It also depends on how much muscle is at risk as well. So all of those factors go into to the ultimate plan for therapy.
Yeah. So after you finish your residency, how many years do you spend as a surgeon?
So I practiced for about 25 years before I left direct practice. Now I still do consulting. I still see cardiac patients for the Federal Aviation Administration, for example, and consult on complex cases.
So what are you working on today?
So today I'm working on the challenge of taking people with abnormal physiology and allowing them to fly in space. So when you think about it historically, we've taken uh, test pilots who were the best of the best and the healthiest of the healthiest, and they became the astronaut corps, men and women, right? But now, with all the commercial space programs, we're sending people with at advanced ages. William Shatner was 90, 91, and abnormal physiology to space. And what we're learning about the acclimatization to altitude and other things has implications for how we can prepare people for space. One of the things I was hoping we'd sort of talk about, since this is really STEM derived, is that the space ecosystem is a reality. And they expect that to be valued at about $2 trillion very soon. They expect hundreds of thousands of people to be working in low Earth orbit in the next couple of years, particularly with the replacement of the International Space Station. So how do you get people ready for that? How do you train them for that? So it starts with STEM in a very real sense, sometimes with a specific focus, perhaps on space-related science.
Yeah. So, what kind of abnormalities are you talking about?
So people we send to space, they might be in poor conditioning, they might be obese, they might have chronic lung disease, they might have been smokers, they might have had heart attacks in the past. They might have other physical ailments. They might have had congenital heart disease that was repaired. It's the whole battery of the human condition that will ultimately go to space. In fact, for example, the MIT Media Lab is very interested in the democratization of space. So they have a lot of programs where they're looking at physical and other handicaps, and what sorts of accommodations would be required for space habitation or space travel. And as we look to include people with those challenges, we learn better how to take care of everybody else, both in space and low Earth orbit, and and as applied back on Earth.
Yeah. Um, how many of these commercial or like space or like people have went into space, like outside of NASA or
Right, right. So remember now that NASA is becoming more and more integrated with the likes of SpaceX and soon to be Axiom and Virgin Galactic and Blue Origin, which is Amazon. And so flights are happening almost daily, some weeks,
really?
among the different vendors. And as you look at the future, um, NASA and even some of the military is becoming more and more dependent on commercial entities like SpaceX for launch, for orbital access.
Yeah. And then, so you're saying these are happening daily? Are these people just going into space and then coming back?
Right. So some of it's tourist space tourism, but some of it, and even the space tourism, is combined with medical study and and scientific study in some sort. But very much there are several commercial entities that are looking to build replacements for the International Space Station. The space station will be decommissioned by the end of this decade. And the new stations will have larger laboratory capability, will have manufacturing capability, will have habitation for long-term stay to a greater degree. And so all of that design, testing, an actual launch. In the case of Axiom, for example, their capability in low Earth orbit connects to the current ISS. And so when the ISS is defunctionalized, the Axiom components will remain. Some of the other companies are a little different. Hmm.
Uh, what are some of the effects on the heart when someone goes to space?
Well, one of the first things that happens is that the blood literally rushes to your head. So I'm being a little facetious. It's not just blood, but one of the things that the astronauts um, suffer, if you will, in low Earth orbit is about a 2-liter shift of fluid up to the head. So very often, if you see astronauts during the initial part of the space flight, they're all puffy because the fluid is up there. That has the effect of impacting vision. It also affects the blood-brain barrier, and so can affect cognition as well. And so among the things that people are working on is how do you bring that fluid back down? How do you redistribute the fluid so that it doesn't have a functional impact? And there's the astronauts exercise quite a bit in space. We don't see that, but they do it hours a day to try to combat that and to also combat the relative atrophy that occurs because they're not fighting gravity with their muscles, including their heart muscle.
Yeah. Yeah. All right then. Thank you for meeting with me today.
Yeah, it's my pleasure. Any last questions, thoughts?
Um, do you have a particular surgery that you really enjoyed?
Well, transplantation was great, just because it's such a dramatic opportunity to help somebody. But I think again, one of the things over one's career, regardless of what you do, whether it's medicine or not, is the ability to help other people is one of the most rewarding things. In preparation for this, you sent me a couple of notes in terms of how people should choose their pursuits. And maybe I'd leave that as a parting note. And I would say that you can choose what you want to do on an intellectual basis or what you think you will enjoy. But as you go through that, you've got to see what actually gets you up in the morning and follow your passion. Because if you follow your passion, that'll keep you intellectually stimulated. It'll keep you enjoying that. Steve Jobs said, if you love what you do, then you never work a day in your life. And I think that's very true.
Thank you.
Okay. My pleasure.